And now I have the privilege of introducing our presenters for today. Dr. Rajesh Agarwal is a professor in the Department of Pharmaceutical Sciences in the Skaggs School of Pharmacy and Pharmaceutical Sciences, and is a former co-leader of the Cancer Prevention and Control Program at the University of Colorado Cancer Center. Dr. Stacy Fischer is a professor in the Division of Internal Medicine, Department of Medicine in the University of Colorado School of Medicine, and is a co-leader of the Cancer Prevention and Control Program at the CU Cancer Center. Dr. Jamie L. Studts is a professor in the Division of Medical Oncology, Department of Medicine in the University of Colorado School of Medicine, and is a co-leader of the Cancer Prevention Control Program at the University of Colorado Cancer Center. I would like to take a moment to thank our presenters for being here with us today, and I will turn it over to you.
Well, thank you very much, and I appreciate the opportunity to speak with everyone today. I am going to do the digital magic of making sure my screen is presenting before we transition, and I hope you're seeing what I want you to see. But I think this is a really unique opportunity, and we really appreciate the chance to share a little bit more about the Cancer Prevention Control Program, but also to express our appreciation for everything that your large and talented team does to support research at the institution. And if there's ever anything that the Cancer Prevention Control Program can do, clarify, support, or maybe cause you less headaches, please let Stacy know, and she will be sure to solve all of those issues. But so my task to start with today is to share a little bit about some background about cancer prevention control in general, a little bit about our research program, and then each one of my colleagues, Raj, will share with you a little bit about some examples of our AIM-1 research, and this will make more sense in a minute after I present you the aims. And then our second AIM research will be presented by Stacy, which focuses on a little bit more survivorship palliative care. And then I'll give you some examples of cancer prevention control research that focuses in on implementation science and health services and population data science kinds of things. And then we'll kind of wrap up with a brief discussion of the population health shared resource, and then be happy to answer any comments or questions or have any kind of discussion. So cancer prevention and control is usually thought of as along a continuum, and this is how the NCI sees it in terms of thinking about from beginning of etiology through prevention, or I prefer the term risk reduction, early detection, diagnosis, treatment, survivorship, and as well as end of life. And then oftentimes population science also includes these cross-cutting areas of different methods and approaches that I'll talk about a little bit more in a little bit. But this is the NCI's definition of the cancer control continuum. I see it just a little bit differently because, like I said, I've added on the end of life question. And while it's commonly called the cancer control continuum, it's not nearly as linear or as segmented as it seems when it's commonly depicted, because individuals, unfortunately, as you guys know, sometimes transition back from a predominantly survivorship-oriented phase to a rediagnosis or a recurrence. And going through a second diagnosis or other kind of procedures, or sometimes survivorship actually includes prevention and risk reduction for recurrence, or prevention activities to present a second primary. And so we can draw a lot of these other connections to try to get the notion that it's not always as linear as it seems like on this continuum. Additionally, survivorship is a bigger compartment than we usually depict it on here. Formerly, we used to think of survivorship beginning at the time that you end treatment, or a long time ago, you weren't technically a survivor until after you've made it for 5 years past diagnosis. Well, we work toward disavowing any of those notions, and that actual survivorship begins from the time of diagnosis onward. And so we don't like to compartmentalize survivorship in the same way as it has historically. So these segments fade into each other and go back and forth. It's a very heterogeneous field with regard to what constitutes cancer prevention control research. Raj will talk to you about some very important basic science work on chemo prevention and immunoprevention that starts in laboratory and works with animals and then transitions to human work, but also the social science of cancer prevention control, the behaviors around screening and survivorship, clinical science, developing interventions to manage symptoms and to palliate, some of the challenges, whether it be side effects of our treatments or actual side effects of disease. And then population data science, looking at how healthcare is delivered on a health services or different kinds of population level to the monitoring incidence and mortality across the country or in states or in counties or in certain specific subgroups. All of this constitutes cancer prevention control research. And we use quite a range of methodologies to do that, from obvious laboratory methods, qualitative studies, survey methods, combination mixed methods, clinical trials, pragmatic trials, data science methods, cost effectiveness, implementation science methods, community engaged research, community participatory methods, and probably a whole group of methods that I have forgotten or didn't have space to put on the slide. But it's really a heterogeneous, and that can be a headache for managing the science in some ways because there are so many different ways to do it. It also includes a broad array of different scientists. We have behavioral and social scientists that are very commonly involved in cancer prevention control research, but also population data sciences, health economists, health services researchers, population data scientists. We have a whole cadre of clinician scientists with backgrounds and disciplines in medical oncology, radiation, palliative care, rehab medicine, dermatology, oncology, nursing, as well as our basic and laboratory sciences. And like Raj comes from a background in pharmacology and pharmaceutical sciences, but we have nutrition scientists and other folks who spend a bit more time in the lab than some of the others. And so, as you've already introduced our team here of cancer prevention control researchers, each with slightly different areas of expertise. And Raj will eventually talk a bit more about the science that we do to address AIM 1. Our AIM 1 in the cancer prevention control program is to reduce cancer risk by discovering and evaluating novel approaches to prevention, screening, and interception. It leans into our expertise in developing novel chemo prevention strategies, using immunoprevention strategies to reduce the likelihood of someone developing cancer or experiencing a recurrence. But also, some of this work includes delivering screening programs and how do we reach different communities. And then our second aim, which will be presented by Stacy today, is to advance cancer survivorship and palliative care by developing and testing innovative interventions. Now, this is critically important because of the success of our research infrastructure to treat cancer more effectively, that we need to be concerned about what happens after cancer treatment, and in terms of the survivorship experience and the palliative care that we can deliver from the point of diagnosis forward to make sure that people are not just living longer, but living well longer. And then our aim 3 is to decrease the burden across the cancer spectrum through fundamental policy, health services, research, data science, and implementation strategies as well. And this is one of the things that is critically important to understanding how cancer care is happening. What is the burden? What does it look like in Colorado? How are we doing better than other states, or how are regions within Colorado doing better than other regions? And how do we try to address some of those gaps that may be experiencing health inequities? And that's really our cross-cutting theme. One of the things that unifies all of our work is a desire to end cancer health inequity in terms of the care we provide, in terms of the outcomes experienced across the board. So before I turn it over to Raj, I just want to say a couple more things. And one is that over the past several years, we've experienced a dramatic growth in the funding and research portfolio of the Cancer Prevention Control Program. Just since our renewal of the Cancer Center Support Grant in 2021, we've experienced a 125% increase in our NCI research funding, an 80% increase in other peer reported, peer reviewed science. And this year alone has led to 8 new federally qualifying awards that really, will lead to more cancer prevention and control research. And so I'll stop there and turn it over for Raj to address a little bit more about some of the research conducted to reduce risk and on interception and chemo prevention.
It looks like we have you muted. I think you're muted there. There you go.
Thank you. So thanks, Jamie, for this introduction, and Victoria for arranging the session. And I will try to be as low as possible on the basic science words and all that. So Jamie introduced specific M1 of our program, and he said cancer interception. So I will walk you through where we started and why it become cancer interception. So that's what I'll try to do in next maybe 2 hours or so. Let's see how that goes. Okay. Okay. So all we're talking here is something interception, and the question here is that what we're trying to prevent, which is not preventable otherwise, and what we're using for that prevention. So if you recall, the first thing or first word Jamie had on his slide was etiology. So etiology is something which happened by any given toxic insert which causes a normal cell to a non-normal cell. So that's etiology. That's the start of cancer process. So the overall idea when cancer chemo prevention research started in 1970s was to just control the occurrence of abnormal cells or etiology, or slow down or reverse the generation of etiologies using the natural compounds or synthetic compounds. And the whole idea was to overall reduction in cancer incidence and multiplicity. So if you stop etiology, nothing will happen, obviously. And we just keep working on it for a fairly long time. And then I think in early 2020, early 2000, NCI came back and said that this approach is not working. We cannot stop the cancer etiology. It happens and it will keep happening. So then the question was what we can do where it makes more practical sense for the cancer chemo prevention research. So if you remember again Jamie's slide, post etiology, there are steps, and the idea was that once you diagnose the cancer, so that cancer could be at a precancerous stage, and before it goes to clinical cancer, we can use that window and slow down the growth of precancer lesion to cancer or something like that. So I have some examples here. One example is prostate cancer. As we know that patient with prostate cancer eventually have different conditions, and one of the most important is the prostatic intraepithelial neoplasia. We call it PIN. And there are ways to diagnose pain in the patient. And those are the patient, we know that if nothing is done, that pain will eventually make into the prostate cancer. Several of us may also know that people who are 50 plus old are encouraged to go for colonoscopy. And the idea there is to see polyps. And these are again precancerous lesions. So you have them or you take care of them or not, eventually they become adenocarcinoma of the colon. So the idea is if you have polyps, you see in colonoscopy, you try to take them out. And then the frequency of colonoscopy changes if you have polyps versus if you don't have polyps. If you don't have, it's 10 years. If you have, usually they encourage 5 years. So that is how that model is set up. Same thing for skin cancer. So actinic keratosis is a very common stage, which is the pre-cancer stage for the skin cancer, and eventually it changes to the squamous cell carcinoma of the skin if nothing is done. So the idea here is to reduce or eliminate the cancer lesions or inhibition of the progression. I'll come in a minute what is progression. And this is more practical, this is more translational. And I tell you why, because if I tell anybody that you do this from your regular life, they don't listen. If somebody who walks in as a patient who has PIN condition, I have been working in prostate cancer for 30 years now, they are very keen to get in clinical trial for chemoprevention. Same thing for colon cancer, same thing for skin cancer, several other cancers. So once they have the first condition, which they know will lead to a cancer, then they are more willing to participate in clinical trial and follow the lifestyle change and everything. That's why it is practical and it is more translational in terms of doing something good for those patients. So I'll just give you some background about the cancer using the model of skin cancer, non-melanoma skin cancer. And the reason is that almost for sure 40 years back, I started working with the non-melanoma skin cancer and spent all my time. Even today, I have a big program on skin cancer with this particular model, and done a lot of work in that cancer as well. So why skin cancer is most important and why we should be caring about skin cancer. So the skin cancer, which is non-melanoma, non-melanoma is the cancer which is from the keratinocyte. So skin has a lot of cells. Most of the cells are keratinocytes. They are not colored. And some cells are melanocytes, which are colored. So the cancer which comes from keratinocytes is because of non-melanoma, so it's like non-melanoma skin cancer. So it is almost 50% of all the cancer diagnosed annually. So you can see the intensity of this cancer. So if you have million cancer, 500,000 are skin cancers, non-melanoma skin cancer. So this is a serious health condition. And the problem with that is that it is caused by the solar radiation. So we cannot stop going out in the sun to avoid this cancer. We use sunscreen, we do a lot of other things, but still this cancer is keep rising and it's totally not controllable. So people still have half the cancer as the skin cancer. So this is the premise behind why I have been working on this cancer, and I will try to keep this whole thing as simple as possible. So normal cell is a normal cell you have here. So whether you're using solar UV radiation or you using tobacco smoke or virus or you name anything, it eventually lead to a damaged cell. In case of skin, we call it sunburn cells, and all of us in this call know that what is sunburn. You go in sun, you get burned, it's a sunburn. It's as simple as that. What happens after that is there are different processes in the skin which take care of repairing this cell. But always is a possibility that the cell, all of them are not repaired. And these non-repaired cells in the next stage have the option or rather pushed for death. And then everything is good. And still we have some cells which are not dead or repaired. Then you have a cell which is like the first stage of tumor induction, we call it initiated cells. In non-melanoma skin cancer, there is a tumor suppressor gene which plays major role, and that is P53 tumor suppression. There's a mutation in that gene, and makes the cells ready to go for the next step. This is important. We thought initially that we can make this process not happen, but we failed. So now we try to do something which is more practical. So now you have this initiated cell, whether it's from UV or anything. Now it's a laundry list of pathways and mechanism, and nobody can say for guarantee that this is involved or not involved. It's like a laundry list of pathways and mechanism. And what they do is they make this one cell into so many cells. And this is your pre-malignant visible tumor, whether it's prostate cancer, we call it PIN, or colon cancer, we call it polyps, or skin cancer, we call it actinic keratosis. So this is the stage which we can control to go from here to here using the chemopreventive approaches. And if you don't, eventually you have the clinical cancer. So this is the whole process from a normal cell to the cancer. And what do we expect from an ideal chemopreventive agent? Of course, we are looking for little to no toxicity. We already have a lot of drugs to treat cancers, which are already toxic, as we know, and high efficacy against multiple sites. So, you know, as I said in previous slides, that most of the cancer follow common kind of mechanistic pathways. So the idea is if you have something which is good for one cancer, should be good or could be good for other cancers as well. A capability of oral consumption, everybody like the pills. So you take a pill and move on and hope everything will be fine. And this is the idea behind this approach as well. Known mechanism of action. So once you know the mechanism, you can better target the cancer, and that's the idea here. And low cost. Of course, the idea is to make people change certain ways of lifestyle, and they don't want to spend a lot of money on that, so it should be cost effective. And lastly, but not the least, human acceptability. So if something not acceptable to human, who cares? So these are some of the commandments. So everybody should be following when you're developing in the cancer chemopreventive agent field. So keeping all those things in mind, chemoprevention research, and this is a nutshell of 30, 40 years of research, what we have in this slide. So we have used over time fruits, vegetables, diet, exercise, nutrition, supplement. All of them are here on this slide. You can see fruits and vegetables. You can see exercise. This guy has been running forever, and see how thin this guy is. The lady has been diet and exercise, and we have a lot of supplements. So it's a total package. What is not good here? They're untargeted. Cancer has so many targets. These things, you can say it's a bad thing or it's a good thing. You take these things, they help reduce the cancer, but they're not targeted to a molecule or to a pathway. But see the importance of this whole idea. So you have initiated cell. I said, no, you cannot control it. Now you have initiated cell from normal cell, I'm sorry. So now it's in the clonal expansion and further growth to clinical, and you have different pathways. All this you see over here, they target these different pathways. They may target several pathways or one pathway, but it's like total package kind of thing. The bottom line is you reduce this stage and this stage. So that's called chemoprevention untargeted. Now, next is chemoprevention and also immunoprevention for that matter. And this is targeted. So what is the difference? Now, the difference is you develop chemical compounds, or you develop, some kind of antibody for the immunoprevention research. And you say that this is a targeted approach. A lot of research has been done developing the kinase inhibitor. So its kinase inhibitor fall right in the front over here. Activation of growth signaling, induction of growth-related early response genes. So once you target signaling pathway with the kinase inhibitors, lot of things here will not happen. So that's a targeted approach. We have compound and drugs for ODC, which was major role is ornithine decarboxylase enzyme. We have selective inhibitor of ODC. They have shown a lot of effect. Even today, they are in clinical trial for colon cancer, which is very important molecule there. COX-2, we all know COX-2, Cellcoxib, and all those drugs, they were targeted for COX-2, and they have shown a lot of efficacy. And we are going very well in that till it came to the point that those drugs have some kind of cardiotoxicity. Sonic hedgehog inhibitors, which is also part of the PAT gene and all that, they're also selective inhibitors, and they have shown a lot of success, not only in treatment, also in the chemoprevention research. And then immune targets like, PD, PD1, PD1L, and all this. So whenever you have a protein, you target it, then it's immunoprevention, because you have an antibody and your protein is a lock and key kind of situation. So you have a key that's going to the lock and blocking the function of this whole protein, and that's the immunoprevention research. And we have a lot of success in the past with that, and even today we have a lot of work going on in the immunoprevention, especially in the lung cancer arena with a couple of our cancer center member, Bob Keith, Miller, and some other people. From chemoprevention, angioprevention, there's another mechanism and pathway to prevent is called cancer angioprevention. So in 2005, almost 20 years back, we were the first to coin the term angioprevention, and we coined it in AACR meeting in 2005, and it changed the whole idea of chemoprevention research. That point onwards, the idea was that everything I've talked before, we're trying to target the cancer cell, but this is more about not only you targeting the cancer cell, but you're also targeting the machine that feeds to the clonal expansion of those cancer cells. I'll come to that in a second. So my lab was the first one to get the first R1 grant from NCI to work in this area in terms of angioprevention of lung cancer using compound. I've been working for almost 30 years now. And even today, as we're talking, several research groups around USA, our campus, and elsewhere use the exact same word, angioprevention, for a lot of research, and it's almost 20 years from now. So the question is, what is the big deal? What are we talking here? So look at this tumor. This is a tumor. You have somatic mutation, means you got the initiated cell, clonal expansion, you got a little tumor here. This tumor is, guess what? Dormant. It is not going anywhere. This tumor needs a machine for this monster growth. And that machine is generated by the tumor itself, where it secretes some kind of molecules. We call it angiogenic molecules, angiogenic factor, and the blood vessels around tumor, they start growing using that factor, and see they start going here, and guess what? They have taken over the whole tumor with the growth. And this is something we call angiogenesis or angiogenic switch from dormant tumor. And the idea is that you want not only to prevent this, you also want to prevent this. And that is where angioprevention becomes the more practical and more approachable approach. And a lot of it, which I cannot cover everything, the time is the tumor microenvironment. 20 years back, we also developed this whole model of tumor microenvironment plus angiogenesis for the angioprevention research, and this has been very successful. So with that, if I just combine everything for the angioprevention, you have normal cell become the initiated cell or first damage, then your dysplasia cell growth start happening. But in this whole process, you need angiogenesis to make the tumor growth to a point as a clinical tumor, plus you need angiogenesis for the tumor to go different part of the body which is called metastasis. So if you can prevent that angiogenesis by biopsy, phytochemicals, or anything for that matter, that is the angio prevention. And that's also a very important component in the chemo prevention research. So now the question is, how about cancer interception? And if you believe me, in the modern time, it was decided by someone I will not name here to call cancer chemoprevention as cancer interception. So we stop calling cancer chemoprevention, we start calling cancer interception. So the name has changed, science has not changed, and everything else which is happening behind that science has also not changed, just the name from cancer prevention, chemoprevention to cancer interception. So these are some of the people, I cannot cover everybody on the slide, who have been working in my lab for a lot, 30, 40 years, doing a lot of work. And I always say that I have had almost a couple of dozen major grants from different funding agencies, and half of them, as you see, almost a dozen of R01 grants, which has been running my program. Still, I have one. And that's where I'll stop, and I'll let Stacy talk.
Thanks, Raj. Well, if anything can really explain the depth and breadth of our program, I think it's the contrast of our AIM 1 and all the wonderful basic science that Raj was able to show, and then shifting gears to our second aim, which is to develop and test innovative behavioral, psychosocial, and palliative care interventions targeting cancer survivors. And as Jamie mentioned, that survivorship can, we really conceptualize that as starting from the moment of diagnosis. And so as a lens, as we're going to talk through some of the work of our program in AIM 2, I'm going to really look at it through the lens of combining our catchment priorities and the Colorado Cancer Plan. So those of you who are familiar with the Colorado Cancer Plan, it was a very large community, based project with people from across the states, very interested in understanding the roadmap of reducing the cancer burden in Colorado. And so all these folks got together with many of the folks from our cancer center as well to develop this cancer plan that's very, very comprehensive. So it's easy to see how much of the research could fit within that. And when we think about our catchment priorities, and for the cancer center, not our clinical enterprise, but our research cancer center, we think of the whole state of Colorado. And we have informing our cancer center is a catchment steering committee, or catchment, made up again of leaders, community leaders, nonprofit leaders, interested parties from across the state who have helped us as the cancer center identify where are our priorities. And it's really, I think, a major part of that priority is thinking about things through an equity or disparities lens, which is really a priority across all the goals, and also something that is an overriding theme in the state's cancer plan. Specifically, that means Hispanic and other underrepresented minority persons, looking at the impact of poverty on cancer, and rurality. And so I thought not knowing the audience, I thought I'd take one moment and just explain palliative care. So we think of palliative care as a specialized medical care for people living with serious illness. It can be focused on providing relief from symptoms and stress, and the goal overall is to improve quality of life for both the patient and the family. So I was looking for pictures of palliative care, and there are a lot of hands. And as you can see from this, there are a lot of hands when you kind of type in palliative care and look at an image search. Not sure why, but grasping hands seems to be central to what we do. So palliative care can be provided by a specially trained team of doctors, nurses, and other specialists who work together with the patient's other doctors, such as oncologists, oncology teams, and clinicians to provide an extra layer of support. It's based on the needs of the patients, not necessarily on the prognosis, and it's appropriate at any age or stage of serious illness and can be provided along with curative treatment like chemotherapy or radiation. And it's also really important to note that it has been recommended, early palliative care has been recommended by NCCN, ASCO, and the American College of Surgeons. This is a fundamental part of oncology care from our best recommendations. So when we think about the cancer treatment across the continuum, I'm going to focus on these again. This is goal 6 from the Colorado Cancer Plan, and thinking about what are the recommendations. And it's really to think about this idea of shared decision-making. How do we support patients and their caregivers about treatment? And how do we kind of prevent and mitigate some of the long-term effects? Also considering some of the geographic barriers that impact this, and thinking about increased testing for emerging therapies. So I'd love to share and shine a light on some of our mentored members' work within our program. Liz Kessler has developed a framework called ABC 123. It was originally designed for advanced bladder cancer. She's expanded it to any kind of newly diagnosed or newly recurrent advanced cancer for older adults. It involves things like screening patients for their frailty, doing a geriatrics assessment, understanding the toxicity formally of chemotherapy, and then really sitting down and talking to patients about their goals of care, and then using all that information to help make a care plan that matches patients' priorities. Why is this important? Well, when we talk to patients, what we find is that overwhelmingly, it's really important for them to be at home as much as possible. But what can happen with a new cancer diagnosis is that people end up spending a lot of time in the hospital, which kind of leads to the second program of research that I'd love to highlight with one of our mentored members, Sarguni Singh. One of the things that we see oftentimes as clinicians, especially when someone with cancer and an older adult gets admitted to the hospital, and then they're not quite strong enough to go home. And so they end up getting discharged to a skilled nursing facility. And then that can start a merry-go-round where they go to the skilled nursing facility, but they don't really regain their strength. And then a complication happens, they end up back in the hospital. And then that whole cycle repeats itself. And so she has developed, in conjunction with some of the palliative care social workers, the Align intervention, which is a social work intervention to provide palliative care for adults with cancer in skilled nursing facilities. So the Align social workers will meet with patients while they're in the hospital, follow them into a skilled nursing facility, continuing things like goals of care discussion, advanced care planning, and helping communication with the patient's outpatient oncologist and the care team that's on the ground in the SNF, helping with those difficult transitions. And then when someone says, I really just want to be at home, can help that merry-go-round or that revolving door stop and forgive the pun, realign the priorities to allow patients to be at home. When we start thinking about advanced care planning, it leads to the next program I'd love to highlight, which is some of the work of Jed Brubaker, again, one of our mentored members, supported by an NSF Career Development Award. He's taught me a lot of really interesting facts, including that most of us have over 200 digital accounts, and that they really have no way of kind of managing them or thinking about the future and what's going to happen to them. And that these platforms really haven't been designed with the very real reality that all of us will eventually die someday. And so these kind of platforms like Instagram and Facebook have become our photo albums, have become our memory books. How do we plan for stewardship and legacy to protect those accounts for those we leave behind? Shifting, I want to talk a little bit about, and I think this is particularly germane to this audience, when we think about participation in high quality clinical trials. This isn't necessarily our research, but I do want to give a shout out to these opportunities. And one of them is the newly formed COE Cares. So this has been, it's a patient advisory panel. It's been formed in conjunction with COE. I've been working on this along with Jennifer Reicher, who used to lead the THI program. And to build a patient panel where any investigator, and especially thinking about those who may be thinking about IITs and how to bring patients and the caregivers into the research, how to design a project with patients in mind. And especially considering some of the challenges we know in terms of ensuring a diverse patient population, ensuring that we could have representation of patients that may live in rural areas. So this panel meets once a month. If you are interested, please use your phone and look at that little QR code. We'll continue to advertise opportunities to come and present to this group because they're ready to go, and they're so excited about science and learning about the research that's going on at the Cancer Center, and also ready to provide their real lived experience as patients and caregivers. The COE group has also developed a video, which will be probably coming live soon, to tell patients about clinical trials and to help. It's both, they've developed it in English and in Spanish, and we've been working with the UC Health navigators across the system to try to work on how we'll disseminate that video to patients in the future as well, to increase our clinical trial enrollment, which, as we all know, is a major priority. And then finally, thinking about the cancer treatment across the continuum. How do we improve physical, mental, emotional, behavioral, and financial well-being? Well, that's a big charge, but there are some phenomenal trials going on, and I'm going to go really quickly through them. Several laboratories. The Arch Laboratory, Joanna Arch is a CU Boulder psychology researcher who has developed acceptance and commitment therapy adapted for treating anxiety, treatment adherence. Kathy Bradley, who's our deputy director of the Cancer Center, has been conducting a clinical trial of cancer caregivers and how they're struggling and kind of meeting the demands of both work and family. Those results of that clinical trial will be available soon, I believe. There's a really fantastic exercise physical activity research program. Heather Leach, Ryan Marker are all working with not only patients within our Cancer Center, but also virtually really reaching out to those rural patients. And then my own program of research, which is focused on psychedelics right now, using psilocybin-assisted psychotherapy to address advanced cancer-related psychiatric distress, and an IIT that's coming out that will look at fear of recurrence using psychedelic-assisted psychotherapy. And that's all, and I'll turn it over to Jamie.
Well, thanks, Stacy. I think you guys are probably getting a pretty good notion of the depth and breadth of the topics that we address, and so I'm going to highlight just a couple of more, because one of the things that we focused on our laboratory science that have done and started into clinical work, and then Dr. Fischer's really highlighted a lot of the clinical activities and interventions that we do to support individuals diagnosed with cancer, sometimes using the survivorship frame, sometimes using a palliative care lens on things, and doing everything we can to support. One of the other things that we're doing is trying to expand access to lung cancer screening and other kinds of cancer screenings across the state, recognizing that some areas of our state have a difficult time accessing these services. Lung cancer is the leading cause of cancer mortality in Colorado and across the U.S. And so with leveraging the Colorado Implementation Science Center, which is funded by a P50 grant from the NCI, as well as Dr. Glasgow's leadership of the REAIM program and REAIM framework, trying to understand how do we bring lung cancer screening more effectively and equitably to Colorado. And we started off with a survey that was led by Dr. Glasgow, and found that, in somewhat surprisingly, because it's not this way across the rest of the country, when you ask primary care practitioners what they're interested in having help with regard to cancer screening, they actually said lung cancer screening. And so it gave us a hint that maybe this could be something that is on their radar. But when we dug into it, we did some follow-up qualitative interviews with primary care clinicians. One of the things that they really wanted to do was to figure out ways to work as a team and integrate more of their staff into the process of implementing lung cancer screening, but also to have better communications and relationships with the lung cancer screening programs that are conducted outside of primary care. And so we've really started to identify strategies of which help people transition, or help clinicians transition from this early adoption of lung cancer screening to a point where they can maintain and sustain the engagement with lung cancer screening, and helping more of their patient panel have access, with a particular emphasis on the rural and frontier communities that are being served by many primary care clinicians outside of the Front Range. Another one of the areas with regard to health services research and population data science is led by Dr. Kathy Bradley and Marcelo Perrion, but also another example of work being done by one of our mentored members that was also highlighted by Dr. Fischer, and that is taking multiple data sources that we have. We have the Colorado Central Cancer Registry data, but how do we merge that? But that doesn't necessarily provide very detailed data about what care is being provided. And when you can take that data and merge it with other sources such as SEER Medicare, or the claims database that we have, we can get a much richer understanding of what precipitated the cancer, what kind of cancer care they received, and what their outcomes were. And this is really innovative research that develops tools to understand the delivery of cancer care. And these linkages, while one would seem to think that they should kind of fold into each other quite elegantly, is actually requires a Herculean amount of work. One of the other things about the Cancer Prevention Control Program, like is highlighted by Dr. Fischer, is that we do work on the problems of cancer in Colorado, and that level of ongoing engagement with the cancer catchment challenges here that are identified based on the epidemiology, but also aligned with the Cancer Advisory Committee, which helps us highlight our challenges and opportunities. And so Dr. Laura Scher is doing some really pioneering work on helping women understand their objective risk for developing breast cancer, and how that might impact their participation in mammography. A recent addition, Dr. Miriam Ascari, was recruited to study skin cancer. And as you might know, Colorado, while in general our cancer burden is lower than most other states, skin cancer is one area where we actually have a higher risk than other states. And so Dr. Ascari is working to understand some of the basic science and laboratory work around skin cancers that spread. We've already highlighted Dr. Leach's work that's really looking at colorectal cancer. And then another project is really leveraging the unique cannabis environment in Colorado, led by Drs. Angela Bryan at Colorado and Kent Hutchison here at Anschutz, to look at symptom management benefits associated with cannabis, as well as cannabinoids with CBD oils and things like that. We also have a heavy emphasis on community engaged work and partnerships with clinicians and with practice-based research network, as highlighted by Dr. Glasgow's work. Betsy Rizendahl is a faculty member in public health that works with leads the Cancer Prevention Control Research Network, that's heavily involved with navigation outcomes and research regarding hereditary cancer risks. And then Dr. Baral leads a study of lung cancer and head and neck cancer survivorship care in collaboration not only with St. Mary's SCL Health, but also the Rocky Mountain Cancer Centers. And then as Stacy highlighted, that we do a lot of work in exercise and physical activity. And this particular work by mentioned member Dr. Ryan Marker really works to try to figure out how to use exercise to address cancer-related fatigue among rural survivors. To do all this work, we of course coordinate with a number of shared resources across the Cancer Center, but one that's fairly unique to the population science and cancer prevention control domain is the Population Health Shared Resource. And the Population Health Shared Resource curates a broad array of population-based cancer prevention control databases in terms of, we have a mirror image of the Colorado Central Cancer Registry, as well as the claims databases. And we use those to merge with other resources to look at cancer care and outcomes. We also support population and behavioral cancer prevention control research by conducting surveys and interviews and qualitative data collection, but also doing accrual for cancer research done for non-therapeutic reasons. Now, of course, I can still, and I hope you share with me the definition that it's therapeutic cancer research can actually be symptom management and burden reduction, not just cytotoxic or anti-cancer therapies, but nonetheless, we know what NCI designates as non-therapeutic research, so we'll use that term. And then we really just want to be around to support and grow the cancer prevention control research across the entire cancer center. And so we have two services and technology lines. One is the population data science. That's kind of what I mentioned before, which curates the data sets, helps analyze those data sets, and the behavioral science side, which supports qualitative and quantitative research methods in terms of interviews, surveys, focus groups, but also works on participant accrual for non-therapeutic research trials. And we also do a lot of REDCap programming. And so we've provided today a kind of a jam-packed overview of the breadth of cancer prevention control research, and we still haven't touched on all of it, certainly, but we've tried to give a sense of that, and we'd be happy to answer any questions or respond to any comments about this portfolio of research being conducted by CPC members at the Cancer Center. Thank you.
Thank you, Dr. Studts, Dr. Fischer, and Dr. Agarwal. Any questions? It looks like we have some time for a couple. Feel free to post those in the chat or unmute yourself to ask. While some of our participants may be typing, I just had one comment that the amount of research in the Cancer Prevention and Control Program is amazing. A lot of interesting studies going on. Where can staff members, specifically from CCTO, OCREST, in the clinical research field, where can they go to learn more about these studies that are happening at the Cancer Center in your program?
So one of the things that we'd love to invite your team to attend is our Cancer Prevention Control Seminar Series. We hold a monthly seminar series that includes external speakers. Sometimes we bring luminaries and friends from across the country to talk, but oftentimes we highlight investigations led by our team here at Anschutz. And so we would love to invite you to those, and hopefully you get some of those announcements. We've been trying to spread out those announcements a little bit more widely. For anyone who dares come to campus, we do serve lunch if you register, and but it's still available online as well. And that highlights, a lot of the unique and research that's on the horizon. We tend to highlight the stuff that's getting launched, that's getting going, and with new funding in order to bring more awareness of those opportunities for folks.
Wonderful, thank you.
If no one asks any more questions, I can start calling on names I recognize to see what they think.
am not seeing anything in the chat at the moment.
Sounds good.
Okay, Deb, Emily, I see your names. Do you have any questions or comments about how we can do a better job with cancer prevention control research and make your jobs better?
I love that you called on me, Jamie. Okay, I do have a question. I noticed that the CCTO now has a CPC, a Cancer Prevention Control Group, directed at the CCTO group, which those staff will now run those particular studies, which is new because CPC had sort of been all over the board, which it still is. So my question is, how will you all decide which CPC protocols to open now that there will likely be a broader array of these types of protocols opening at our cancer center through CCTO and non-CCTO avenues?
Yeah, I can take this. I mean, I think we've often, I think, not had a seat at the table with the CCTO. And so we are so excited about building this team. And I've been part of some of those early discussions. So I don't know it will necessarily change the number of protocols opening up, but it will change how we recruit. And for CPC, a lot of, some of the studies are maybe disease specific, but many are not, and really are I call it disease agnostic. Like, for instance, Dr. Bradley's caregiver study, where it's all types of cancer. And so we're working within the new team, this CPC team with CCTO, to really kind of think about how do we build this in a way that we can work with a wide variety of disease sites and be able to target some of the populations that have barriers to participating in research. So specifically bringing in some of the more diverse populations. And so we're working towards that. So I think there's going to be a lot of really exciting opportunities in the future that are probably only a few months away.
Great, thank you.
To add on a little bit to that is I don't think there's going to be any significant conflict in terms of what's supported by one entity and what's supported by another, because the CCTO group is going to be much more skilled at handling projects like the ones that Stacy leads in her team, where agents are being used, where some of those where regulatory is slightly different and management of those, that's not in the skill set of the population health shared resource behavioral group. We really focus on trials that are true, solely behavioral interventions, and really tend to work better in a single disease site kind of activities that are a bit more in our scope. And if there's ever any space where there's some overlap, Marie and I will work together to figure out whether it's a CCTO project, it's a PHSR project, or it could be a situation where it's a combined project, because sometimes we don't dictate what it is. The investigator gets to choose, and maybe they feel more comfortable with CCTO with their project than PHSR, and we need to weigh that into the equation as well. And so obviously there's more than enough work for all of us, and so it does seem like we can work together more effectively. And this is an expansion of support for this type of research, and that we all everyone that I know welcomes.